Good morning everyone. Can you see me? Yes beta. Can you hear me? Okay. So let's start with the lecture. I am Dr. Arvind Arora. I am faculty in Orthopedics Department, SAIT GS Medical College and KEM Hospital, and we are going through the crash course in orthopedics for undergraduate students, especially for those students who are appearing in this FAB for their university exam. So today I am going to take a short lecture of 45 minutes to 1 hour, and I will cover all those important short topics which are usually commonly asked in your exam for short notes or sometimes for long MCQ, long answer type question also. So let's start with those short topics. The first short topic is Trendelenburg test, which is very important for your PG entrance examination as well as for university examination. So in Trendelenburg test, we check for abductor mechanism of hip. We stand or sit behind the patient or person and ask the person to stand on one limb. So here the person is standing on this limb and the other limb is in air. Due to gravity, this pelvis will try to go down, but there is reflex contraction of abductor on this side which prevents sagging of pelvis on opposite side. So on bearing weight on one limb, the opposite side pelvis is prevented by sagging down by these abductors. So this is the normal mechanism. Now in normal mechanism, which all are there in this abductor mechanism, there are various parts involved for proper abductor mechanism to act. First, there should be fulcrum, at which point movement is occurring, and fulcrum here in this abductor mechanism is hip joint. There should be lever arm on which the force will act, and the lever arm is this head and neck of femur. Then there should be some force or some power which is acting on this lever arm to do movement at fulcrum, and the power is provided by abductors of hip joint. Main abductor is gluteus medius, which is supplied by superior gluteal nerve. Now in normal abductor mechanism, which we have discussed just, on standing one limb, the opposite side pelvis is prevented by going down by these abductors. If there is some problem in this abductor mechanism here, so what will happen? This abductor will not pull this pelvis up. So for on standing on one limb, if there is some problem in abductor mechanism, the opposite side pelvis will sag down. This is positive Trendelenburg test. So on standing on the affected side, the opposite side pelvis will sag down because there is defect in abductor mechanism. Now this defect may be due to involvement of any of these. For example, if fulcrum is defective, that is there is problem in hip joint like development dysplasia of hip or dislocation of any type, fulcrum is not in its normal place. If there is problem in lever arm, either in head or neck of femur, so in head there can be avascular necrosis, head is damaged due to avascular necrosis, or in Perthes disease head is damaged. or there is fracture neck of femur, so there is problem in lever arm. Finally, there can be problem in power. These abductors can get paralyzed either due to superior gluteal nerve injury or some other paralytic disorders like poliomyelitis. If the angle between neck and shaft is also decreased, so it will also cause positive Trendelenburg test. So this is the Trendelenburg test, and the causes of positive Trendelenburg test are paralysis of abductor like in polio or superior gluteal nerve injury, dislocation of hip, fulcrum is in not place, fracture neck femur, defect in lever arm, destruction of head, defect in lever arm, coxa vara. So these are the important causes of positive Trendelenburg test, and this has been asked so many times in your university exam as well as in your PG entrance exam. So the next short topic which is commonly asked in both exams is carpal tunnel syndrome. Carpal tunnel syndrome is an entrapment neuropathy where median nerve is compressed in carpal tunnel at the level of wrist deep to transverse carpal ligament. If you know the basic structures, basic anatomy of carpal tunnel, you can easily understand various causes. So in carpal tunnel we have 9 tendons, 4 tendons of FDP, 4 of FDS and 1 FPL, and all these flexor tendons are covered by synovial sheath. Along with that there will be median nerve. So if this synovial sheath it becomes swollen, available space in carpal tunnel will be less. Available space for median nerve in carpal tunnel will be less. So it can cause compression of median nerve in carpal tunnel. So any cause of synovitis. And the most important one is rheumatoid arthritis. It may be tubercular synovitis also. These can cause carpal tunnel syndrome. Now if there is edema inside the carpal tunnel, once again less available space is available for median nerve. So all causes of edema like pregnancy, like hypothyroidism, these can cause carpal tunnel syndrome. Finally, infiltration. Some infiltration is there, like in obesity there will be fatty infiltration, proliferation of adipocytes. In acromegaly, in sarcoidosis or amyloidosis, there will be infiltration. So these are the important causes of carpal tunnel syndrome. In diabetes mellitus, there is already peripheral neuropathy, so already compromised nerves, peripheral nerves. If any cause occurs, this can lead to carpal tunnel syndrome. So these are the important causes, but the most common cause is idiopathic, where there is no available particular cause is there. It is related to increased use of these tendons during day, like in typists. In the day they are using these flexor tendons continuously. So what will happen in the evening, due to excessive use, there will be some inflammation in those tendons, synovial sheath of those tendons, which will lead to overused synovitis. That is why most of the time symptoms of carpal tunnel syndrome are there in night, because in daytime the person is using finger, leading to inflammation up to evening, and in the night there will be symptoms due to swelling of those synovial sheaths. These causes, other causes we have already discussed: obesity, rheumatoid arthritis, diabetes mellitus, pregnancy, hypothyroidism, acromegaly, sarcoidosis and amyloidosis. Clinically, it is more common in females, and the usual age group is between 30 to 50 years. The classical presentation will start pain and tingling in the distribution of median nerve. Finally, there will be numbness in the distribution of median nerve. and symptoms initially will be more in night. And here you should remember, whenever I am saying these symptoms in the distribution of median nerve, in hand sensory distribution of median nerve is lateral 2/3 of palm and lateral 3.5 finger. But these sensory symptom will be there only in lateral 3.5 finger, not over the lateral 2/3 of palm, because the lateral 2/3 of palm, which is supplied by median nerve, it is through palmar cutaneous branch, which is given in distal forearm, and it traverses superficial to transverse carpal ligament. It is not there in carpal tunnel. So in carpal tunnel syndrome, this branch is not involved. So there will be no sensation in this area. This will be normal. This tingling, numbness, pain will be in lateral 3.5 finger, not over thenar eminence, though this area is also supplied by median nerve. Okay, because palmar cutaneous branch is superficial to carpal tunnel. That is why in low median nerve injury, most of the time these sensations are spared. And in long standing cases, there will be paralysis of thenar muscles causing wasting of thenar eminence. There are few clinically described tests, that is clinical test for carpal tunnel syndrome. Most commonly used is Phelan test, wrist flexion test. We ask the patient to do palmar flexion of wrist and keep it for 60 seconds or 30 seconds to 1 minute. And this is Phelan test. The second is reverse Phelan test, dorsiflexion of wrist. In these positions, palmar flexion and dorsiflexion, the available space in carpal tunnel is decreased and there is increase in pressure of carpal tunnel. If there is carpal tunnel syndrome, already compromised median nerve will give tingling and numbness in the distribution of median nerve. Similarly, the test is tourniquet test, where we apply the tourniquet cuff in arm and we inflate it above systolic pressure. So there will be loss of blood supply distal to tourniquet cuff. If median nerve is compromised in carpal tunnel syndrome, it will give early symptom due to ischemia, that is tingling in the distribution of median nerve in lateral 3.5 fingers. Tenal sign we use in all injuries. We percuss median nerve in carpal tunnel, there will be tingling in lateral 3.5 finger, that is tenal sign, that is used for all nerve injuries. And finally, median nerve compression test or Durkan's test, which is the most specific and sensitive test, where we keep median nerve compressed for 30 seconds in carpal tunnel and there will be tingling in lateral 3.5 finger if there is carpal tunnel syndrome. So these are the clinical tests, and the most specific clinical test is Durkan's test or median nerve compression test. Now, investigation of choice to diagnose carpal tunnel syndrome, which will show that there is some problem in median nerve in carpal tunnel only, is electrodiagnostic studies, which includes electromyography and nerve conduction study. Now, treatment wise, initially we start with conservative treatment, that is anti-inflammatory drug to reduce inflammation of synovitis. We give carpal tunnel syndrome, which keep the wrist in straight position. As we have seen in flexion and extension, there is increase in carpal tunnel syndrome, carpal tunnel pressure, which can increase the symptoms. So we give carpal tunnel splint, which keep the wrist straight, and we give physiotherapy, general stretching and isometric exercises. If patient is not improving, we can give corticosteroid injection in the carpal tunnel, not commonly used. Finally, if there is neurodeficit, that is muscles are paralyzed or there is anesthesia in the distribution of median nerve, that is sensory loss is there, in that case surgery is indicated. We release transverse carpal ligament and flexor retinaculum to relieve the pressure over median nerve. So this was about carpal tunnel syndrome. Beta, if any one of you have any query, you can ask me. Anyone? Okay. So we'll go with the next topic, osteochondrosis. You will hear or read your two terms which look similar. This osteochondrosis osteochondrosis and osteochondritis. Now in some textbook also they have incorrectly used these terms interchangeably, but that is incorrect. First I will explain what is osteochondrosis because that is more important. So what happens during bone formation? As you know, in endochondral ossification, first there is formation of cartilage. Okay, during endochondral ossification of bone formation, there is formation of cartilage, then ossification of that cartilage to form bone. That is bone formation through cartilage. Assume there is formation of cartilage for this bone. What will happen? For diaphysis or shaft, there will be appearance of ossification center. First, ossification center will start here, primary ossification center. Then peripherally it will expand, that is ossification will expand in cartilaginous matrix peripherally. Similarly, for epiphyseal area, there will be secondary ossification centers. So ossification will start with these centers and it will spread. So these are secondary ossification centers, and finally it will lead to all ossification here. This is for epiphysis, and secondary ossification center, that is epiphyseal center, will depend on the number of secondary centers will depend on the bone. So they will unite to form a single epiphysis, and this cartilage at growth plate or physis will remain. So this is how a bone is formed. Now what happens in osteochondrosis? Either this secondary ossification center or primary ossification center, they will lose their blood supply. So there is defective blood supply to these secondary or primary ossification center, leading to avascular necrosis of that particular center. So there will be defect in endochondral ossification. All those diseases, Percy's disease, Penner's disease, CVS disease, Osgood-Schlatter's disease, those are osteochondroses, where there is avascular necrosis of ossification center with defective endochondral ossification. Those are not osteochondritis, and they have been incorrectly mentioned in some of the textbooks as osteochondritis. So now what is osteochondritis? Chondro means cartilage, itis means inflammation. So simply osteochondritis means inflammation of articular cartilage. Okay, inflammation of articular cartilage. In some of the osteochondroses which are intra-articular, like Perthes disease. Perthes disease is osteochondrosis of femoral head. It is intra-articular. Head is inside the acetabulum. There may be inflammation of articular cartilage of hip joint. So intra-articular osteochondrosis can cause osteochondritis. So they are used interchangeably incorrectly. The correct term is osteochondrosis. Okay, so now we will use this term osteochondrosis. What is osteochondrosis? Avascular necrosis and defective endochondral ossification of primary and secondary ossification centers, and it is due to defective blood supply. And important osteochondrosis which are commonly asked in your PG entrance exam, and you will have to remember for your university exam also. These are Perthes disease, where femoral head epiphysis is involved, and this is the most common osteochondrosis. Penner's disease involving capitellum. Kienbock disease involving lunate. Osgood-Schlatter's disease involving tibial tubercle. CVS disease involving calcaneal tuberosity. Kohler's disease involving navicular. Schauman's disease involving ring epiphysis of vertebrae. Calf disease, central body of vertebrae. Freebird disease, second metatarsal head. Island disease, fifth metatarsal head. Jonasson-Larson disease, lower pole of patella. And Pries's disease, which is spontaneous avascular necrosis of scaphoid. So these are various osteochondroses. Once again I am telling you, Incorrectly, they have been mentioned in some of the textbook osteochondritis. These are osteochondroses. Now this is next short note which you will get in your university exam, osteochondritis dissecans. So here, as the name is suggesting, itis, inflammation, chondro, cartilage, inflammation of articular cartilage, dissecans, which lead to dryness of that cartilage, and it lead to separation of that cartilage from subchondral bone. So inflammation of subchondral bone and articular cartilage over convex surface of joint. Here you can see this is the convex surface of joint, this is concave. So this osteochondritis dissecans will involve concave articular cartilage on convex surface of joint, and this can lead to separation of overlying cartilage from subchondral bone. And the most commonly affected age group is adolescent period. Most common site for osteochondritis dissecans is medial femoral condyle, this lateral part. So this is, you can see this is fibula. So this is lateral, this is medial. This is medial femoral condyle, this is lateral condyle. So this lateral part of medial femoral condyle, this is the most common site for osteochondritis dissecans. The other common site is capitellum of humerus. Less common sites are femoral head and talar dome. The treatment of this particular condition is, initially we give conservative treatment in the form of bisphosphonates and physiotherapy. If that area of osteochondritis dissecans is large, or there is separation of that articular cartilage from subchondral bone, so there is exposure of subchondral bone, in that case surgery is indicated. And the main aim of surgery will be to cover that subchondral bone. The denuded part of subchondral bone should be covered, because that subchondral bone is very painful. It has high numbers of nerve endings which cause pain. So we want to cover that subchondral bone. And the surgeries through which we can cover that subchondral bone is, we can do arthroscopic drilling in that subchondral bone through with the help of arthroscope we cause drilling. And what will happen, through that subchondral bone there will be bleeding, and blood clot at that subchondral bone site which later on will be converted into fibrocartilage, not hyaline cartilage which is articular cartilage. It will be converted into fibrocartilage that will prevent stress on that subchondral bone, and that will help in pain relief. So we can do arthroscopic drilling in that bone known as microfractures. So if this is medial femoral condyle and this is the area of defect, what we'll do, we will do drilling in this area. There will be hematoma and blood collection. Later on this will be converted into fibrocartilage. Or if the area is little bit larger, we can use autologous chondrocyte transplantation. What we do, we take out cartilage from non-weight bearing area, somewhere from non-weight bearing area where it is not required. We harvest chondrocyte from that cartilage, and then during second surgery we will implant those chondrocyte in the defective space. They will proliferate to form normal hyaline cartilage. So autologous chondrocyte transplantation. If that particular fragment of cartilage and subchondral bone is very large, which is separated from the subchondral bone, we can refix that large fragment with the help of a screw known as Herbert screw. Okay, so these are the surgeries which can be used whenever indicated. So this was about osteochondritis dissecans. The next important topic which is asked in your university exam as well as in MCQs, it is avascular necrosis or osteonecrosis. Avascular necrosis, as the name is suggesting, necrosis of bone due to defective blood supply. As there is necrosis of bone, it is also known as osteonecrosis. Osteo means bone, necrosis means infarction of bone due to defective blood supply. So there is necrosis of bone due to interruption of blood supply. It is overall most common due to trauma known as traumatic avascular necrosis. And important sites for traumatic avascular necrosis where the blood supply is interrupted due to trauma are head of the femur, where avascular necrosis of head of femur can occur by fracture neck of femur or posterior dislocation of hip. There may be avascular necrosis of proximal pole of scaphoid due to fracture of waist of scaphoid. As there is retrograde blood supply in scaphoid, the proximal part is more prone for avascular necrosis. There can be avascular necrosis of body of talus in fracture neck of talus. Finally, proximal pole of lunate may undergo avascular necrosis in lunate dislocation. So these are the important sites for traumatic avascular necrosis. Now overall, most important site for avascular necrosis or osteonecrosis is femoral head. That is infarction or necrosis of femoral head due to defective blood supply. It usually involves anterior, superior and lateral part of head. Imagine this is the head, this is lateral part, this is acetabulum, this will be medial part. So the area involved is this superior part anteriorly and laterally. This area, this is lateral, this is medial, this is superior, this is inferior. So somewhere around this area, lateral, superior, anterior, this area. Why I am telling you, whenever I will be telling clinical manifestation, so I will tell you what is the importance of involvement of this area. Why this area is involved? Because this particular area is supplied by lateral epiphyseal branches of superior retinacular artery, which is a branch of medial circumflex femoral artery. So this medial circumflex femoral artery, posteriorly it is going, here it is going, giving superior retinacular branch or ascending cervical artery. Then this gives lateral epiphyseal branch. So these are involved most commonly. That is why this area is involved most commonly. So in avascular necrosis, medial circumflex femoral artery is involved. More specifically, lateral epiphyseal or superior retinacular or ascending cervical part of medial circumflex femoral artery. Now this cause of avascular necrosis may be traumatic or non-traumatic. In traumatic causes, we have just mentioned in last slide, fracture neck femur and posterior dislocation of hip. In non-traumatic cases, idiopathic, where you cannot find any specific cause, is the most common cause overall for avascular necrosis of femoral head, also known as Chandler's disease. Other important causes are substance abuse like alcohol, corticosteroids, smoking, some hematological disorders like sickle cell anemia, polycythemia, some congenital disorders like slip capital femoral epiphysis, Perthes disease, hyperlipidemia like in nephrotic syndrome, and some miscellaneous causes like Gaucher's disease, Kazan's disease, that is decompression syndrome, pancreatitis, radiation and SLE. These are the important causes of avascular necrosis of femoral head. Now clinically, the earliest symptom is pain, which is the most common presenting symptom, pain in groin, and the pain of hip joint can radiate to knee joint through obturator nerve, because both hip joint and knee joint are supplied by articular branches of obturator nerve. So pain of hip joint can radiate to knee joint through obturator nerve. There will be decreased range of motion, and in early stages this is especially internal rotation and abduction which are involved. Now once again reminding you which area is involved: superior, lateral, anterior. And if you do internal rotation, this area will come into articulation, this area will come into articulation, or you do abduction, this area will come into articulation. So during abduction and internal rotation, that particular area comes into articulation, that can cause pain. That is why the earliest movement restricted are these internal rotation followed by abduction, that is abduction, internal rotation. Later on, once there is destruction of head, all movements will be restricted, but in initial stage it is internal rotation and abduction. As there is pain, patient will be walking with antalgic gait, that is painful limb, and Trendelenburg test will be positive as there is defect in lever arm, head is destroyed. So Trendelenburg test will be positive. One very important sign is sectoral sign or differential rotation, which is very characteristic. If clinically on examination you find this sign, you can say it is a case of avascular necrosis. What is that? In extended position of hip joint, slight internal rotation is possible, but as soon as you flex the hip joint, no internal rotation is possible. That is known as differential rotation. Rotation, that is internal rotation possible in extension but not in flex position of hip. This is known as sectoral sign because it is due to involvement of a particular sector of head that we have discussed, anterior, superior, lateral part. In flex position, as soon as you do internal rotation, that part is going into articulation. So in flexion, there is no internal rotation possible. In extended position, you can do some internal rotation. Radiologically, the first investigation always will be X-ray, which is normal up to 6 to 9 months of disease onset. May be normal up to 6 to 9 months. Not in all patients, but it may be normal. And the earliest finding on X-rays will be cysts and sclerosis. Here you can see this is cyst. This area is cyst, around which there is sclerosis. There will be crescent sign due to resorption of subchondral bone. This bone is resorbed. So there is crescent shaped lucency. It is crescent sign. And whenever you find crescent sign, that is sign of impending collapse of head. As subchondral bone is resorbed, subchondral support of bone is lost. So there will be collapse of head at this area. Later on, there will be destruction of head and arthritis. You can see now acetabulum is also involved. So there is destruction of head, arthritis. MRI is the investigation of choice always, because during first 6 months X-ray may be normal, but MRI can detect avascular necrosis at that time also. So here you can see avascular necrotic. This is line of demarcation between normal bone and avascular area. So MRI is the investigation of choice. Treatment wise, this is the simplest treatment at your level, which you should write down in your university exam. If there is less than 15% of head is involved or involvement of non-weight bearing position, then we can try conservative treatment. We'll give rest, that is non-weight bearing walking on that particular limb, and bisphosphonates. If there is early stage where more than 15% of head is involved, so head is involved more than 15% but early stage, that is there is head is round, there is no collapse. Early stage, head is round, no collapse, and more than 15% of head is involved. In that case, we do surgery, and the surgery of choice is core decompression and bone grafting. What we do in this surgery? Here, in this avascular necrosis, there is increase in intraosseous pressure of head, which causes pain. So what we do? We decompress that area, core decompression. That core is decompressed. And after that, we do fibular grafting, so that we provide support to this neck. We have drilled through this neck, so this area of neck becomes weak. If we are not putting fibular grafting, it may fracture later on. So we put this fibular grafting. So core decompression and fibular grafting in early stages. If there is advanced stage, that means there is collapse of head or there is arthritis. In that case, total hip replacement is only done. Here you can see complete arthritis, total hip replacement is done. Okay, so what is the treatment? Less than 15% of head involvement and non-weight bearing area involved, conservative. If there is involvement of more than 15%, always surgery. If more than 15% involved but it is early stage, there is no collapse of head, core decompression, fibular grafting. If there is collapse of head or arthritis, total hip replacement. Okay, so now we will start discussing some of the important soft tissue disorders. First, bursitis. So simply bursitis means itis means inflammation. Bursitis means inflammation of bursae. What are the bursae? These are fluid filled sacs at the site of continuous friction between bones and tendons, skin or ligament. So there are usually 4 types of bursae. Subcutaneous, where bursa is present between bone and skin, like olecranon bursa, or prepatellar bursa between patella and skin. There may be submuscular, that is between muscle and bone. For example, gluteal bursa, deep to gluteal muscles. Then there can be synovial, also known as subtendinous bursa, below the tendons. For example, suprapatellar bursa, which is deep to quadriceps tendon. Infrapatellar bursa, deep to patellar tendon. And finally, adventitious bursa. These bursae develop later on at the site of continuous friction. They are not present normally. So this subcutaneous bursa, submuscular bursa and this synovial or subtendinous bursa, they are present normally in the body. But these adventitious bursa, they develop later on due to continuous friction. For example, here you can see on great toe, whenever there will be hallux valgus at the head of first metatarsal on medial side, there will be development of bursa, that is known as bunion. So that will be adventitious bursa. So these are the types of bursa. Now if these bursae can get inflamed, they may produce symptom and the condition is known as bursitis. Important bursitis are prepatellar bursitis, known as housemaid's knee, infrapatellar bursitis, known as clergyman's knee, olecranon bursitis, known as student's elbow, ischial bursitis, known as weaver's bottom. On lateral malleoli, it is known as Taylor's ankle. On great toe, medial side of first metatarsal head, there is development of adventitious bursa known as bunion. Similarly, on lateral side of fifth metatarsal head, there is development of adventitious bursa known as bunionate. So these are the important bursitis. Now the next important topic for your university exam is frozen shoulder, also known as periarthritis shoulder or adhesive capsulitis, because due to inflammatory contracture in capsule of shoulder joint, there is adhesions which lead to pain and stiffness. So this frozen shoulder is characterized by progressive pain and stiffness of shoulder. It has characteristic course and stages. The first stage is freezing stage, when there is start of adhesive capsulitis. So what will happen in this stage? There will be pain and start of stiffness. The movement will start decreasing, and in this stage the earliest movement will be restricted are internal rotation followed by abduction. The next stage is frozen stage. So this is the typical stage, name given frozen shoulder. This is a frozen stage where pain decreases and there is increased stiffness. All movements are restricted. And the final stage is thawing, where gradually regaining of all movement. And this disease has the usual course of 1 to 1.5 years most of the time. Freezing, frozen, thawing, and the patient will regain all of the movement. But you should remember, the patient will regain all of the movement only if you are giving proper physiotherapy during that period. Okay, during this progressive course, if we are giving proper physiotherapy, only in that case there will be regaining of full movement. Otherwise patient may develop permanent stiffness. And In more than 95% of the patient, physiotherapy is all that is required. That is motion exercises of shoulder. And for unknown reason, it is associated commonly in diabetes mellitus. That is why in a suspected case of frozen shoulder, we always do sugar levels. Next important topic is painful arc syndrome. What is, as the name is suggesting, painful arc? During abduction, some range of that arc is painful, and that range is 60 to 120 degree. And why there is pain in this particular arc only? As you can see, greater tuberosity, and this is coracoacromial arch. What happens? Normally in adduction, this greater tuberosity is way away from this arch. As you do abduction, what will happen? This greater tuberosity will come here below this arch or acromion process. Normally there is subacromion bursa, and in normal supraspinatus tendon nothing will happen. It will allow frictionless movement. But if there is some pathology in this supraspinatus tendon, that is partial tear or inflammation, so that tendon will be swollen. Once you are doing abduction between the range of 60 to 120 degree, that tendon will get nipped between greater tuberosity of humerus and acromion process, and during that range there will be pain. So causes of painful arc syndrome are partial tear in supraspinatus tendon, supraspinatus tendinitis or calcification, if there is inflammation in subacromial bursa, if there is fracture of greater tuberosity. Treatment, most of the time conservative treatment is successful, that is anti-inflammatory drug and physiotherapy. If conservative treatment is not successful and it happens only in less than 5% of cases, then arthroscopic subacromial decompression is done. We decompress this area so that more space is available for movement. Now we will discuss some of the important tendon or muscle pathology, and the most commonly asked is tennis elbow, where there will be inflammation and micro tear in common extensor origin, and common extensor origin is from lateral epicondyle, so this is known as lateral epicondylitis. The most commonly used tendon is extensor carpi radialis longus, followed by extensor carpi radialis brevis. There is specific test for tennis elbow is Cogen's test, where in flex position of elbow we ask the person to do dorsiflexion against resistance. So the person is doing extension of wrist against resistance using extensor tendons. If there is tear or inflammation in those tendons at origin site, there will be pain in this particular area where we are also pressing with the help of thumb. This is Cogen's test. And similar to tennis elbow, there is golfer's elbow, where there is inflammation in common flexor origin, medial epicondylitis. Treatment is same for both. We give rest, anti-inflammatory drug, along with application of tennis elbow band in this area so that those tendon can get rest. If this conservative treatment is not working, we give local corticosteroid injection at this tear site. And in more than 90% of cases, up to this treatment, most of the patient will get relief. And in rare situation, if patient is not getting relief, surgical decompression at this particular area is required. But that is very, very, very rare. The next short topic is Quervain's tenosynovitis, where there is inflammation and thickening of fibrous sheath, which is common for abductor pollicis longus and extensor pollicis brevis. So patient is complaining of pain over radial styloid area, which can be confirmed by Finkelstein test. We ask the patient to make a fist with thumb inside the fist and we suddenly do ulnar flexion. There will be pain around this area, known as Finkelstein test. Treatment is almost same like tennis elbow. Rest inflammatory drug. Not improving, local corticosteroid injection. Not improving, then surgical decompression, that is release of that tendon sheath. So the final disorder, short topic which they are asking in your exam is Dupuytren's contracture. There is thickening and contracture of specialized deep fascia, that is palmar aponeurosis of hand. This leads to flexion deformity of fingers. First, there is flexion of metacarpophalangeal joint, which is involved most commonly, followed by proximal interphalangeal joint. Distal interphalangeal joint is usually spared. And the most commonly involved finger is ring finger. Ring finger is involved at earliest stage. Later on there is involvement of middle finger also. In some cases it may be bilateral, and due to unknown reason it is associated with these disorders like diabetes mellitus, in alcoholics, in smokers, in pulmonary tuberculosis, and in epileptics which are taking phenytoin or eptoin. This Dupuytren's contracture may also be associated with contractures or fibroblastic proliferation at some other site. Basically, there is defect in fibroblastic proliferation, myofibroblast proliferation. So sometimes it is not restricted to hand only. There may be some other sites only, like Garrot's patch. There is fibroblastic thickening on dorsal knuckle pad. Lederhouse disease, where you can find fibroblastic proliferation in the sole. Peyronie's disease, there is fibrosis of corpus cavernosum. And in treatment, usually we wait and watch and we give gentle stretching, just gentle stretching. We do nothing. Surgery is required only if metacarpophalangeal joint contracture is more than 30 degree or proximal interphalangeal joint contracture is more than 15 degree. In these cases, subtotal palmar fasciectomy, that is part of palmar fascia is removed surgically, followed by soft tissue coverage procedure. Okay, so this was about important short topics. So now onwards I will take these small lectures, and before your university exam I will finish your full orthopedics. Major chunk we have already finished. Now hardly 1 or 2 lecture will require, and then I will finish your course. Further, I will take, before your practical exam, I will take one class on instruments, braces and splints also. If any one of you have any query, beta, you can ask, and you can subscribe my Telegram channel so that you can give suggestions regarding timings of lectures and topics of lectures. The link is given below the video. If anyone has any query, beta, you can ask. Anything? Okay, beta. So I'll finish my lecture. Thank you very much for joining.